Yes, so we will start now.
Okay.
Yeah. Good evening, all colleagues. Welcome all of you to our first neurology talk webinar. I am Dr. Lê Thụy Minh An from Vietnam, and this is my co-host, Dr. Hoàng Tiến Trọng Nghĩa.
Thank you, Dr. Ang, for presenting me. Good evening, Professor Kang Sang Lim and all participants. My name is Nghĩa, coordinator with Dr. Ang. On behalf of the Vietnam Neurological Association, Professor Kong, the president of VNA, and Professor Tuấn, the general secretary of VNA, could not participate in this exciting talk due to some personal reasons. And many thanks to Asna Academy and the VNA for organizing the Asna Neurology Talk #1. And the program goal is to provide continuous training in the field of neurology in Vietnam and also Southeast Asia. Because as I know, in this webinar, we also have some participants, some colleagues in the other Southeast Asian nation. And before starting today's talk, I inform all VNA members that our group has successfully translated the EEG handbook written by three other Professor Ken San Lim, Dr. Su Win Kyo, and Dr. Lê Thụy Minh An into Vietnamese. Okay, without keeping you waiting too long, I would like to respectfully introduce Professor Kang San Lim, President of ASNA, the leading expert in the field of epilepsy, will present to us the topic non-convulsive status epilepticus diagnosis and treatment. Over to you, Professor Lim.
Thank you, Dr. Nia, Dr. Minh An. Let me share my slides. So, thank you for the introduction and invitation as well. This is our first webinar by ASNA, which is ASEAN Neurological Associations. As you can see on the logo on the left upper, this is a logo of ASNA. Today's talk will be divided into three components. The first one will be for the general physicians and medical officers. It will be about 10 minutes. And then I will cover a deeper aspect of non-convulsive status, especially the EEG aspect. And then I will show you some cases related to non-convulsive status epilepticus. But before I go on, I'd just like to make announcements that ASNA webinar will be organized once a month by various hosts in the ASEAN Neurological Associations in the ASEAN countries. And the subsequent one will be hosted by Malaysia in December and Singapore in January, as well as UMMC, which is my hospital, in February on these various topics. So now I'll go on with a case. So this is a 78-year-old woman with other mental states. She has 1 week of increasing fatigue and a single possible seizure with loss of consciousness on the day of admissions. On examination, she has no fever. Her blood pressure is normal, but she was drowsy, disorientated in time and place, no neck stiffness, cranial nerves and limbs examinations were normal. Past history, she got a very mild strokes 3 years ago, and there were some changes in the scan, which I'll inform you later. And she is on medications. Her medications include irbesartan hydrochlorothiazide, aspirin, and also nocturnal lorazepam. But her lorazepam was stopped during admissions because of impaired disorientations in time. So investigations-wise, she had a CT scan showing an infarct on the right parietal regions. The electrolytes were normal. The blood white cell count were elevated, but she has no fever, as I mentioned just now. Urine analysis has white cells and blood presence. Blood culture were taken, antibiotics were started, and which was the cefepime was given. She has progressive deteriorations of mental states with paranoia, hallucinations, and increasing drowsiness. So the question is this a non-convulsive status epilepticus? So normally in the ward, when we see a patient with deterioration, especially an elderly, we will always think about, could it be organic brain syndrome? For example, could it be encephalitis, or could it be encephalopathy due to sepsis, metabolic causes, or drugs, or sometimes due to other factors. In this case, the patient has no fever but have raised total white. The patient was given cefepime. There is no metabolic disorders. The second question we will ask is, could it be seizure related? And the first one will be non-convulsive status, partly because patient was on lorazepam, which was withdrawn. And patient may have developed a new strokes because she has risk factor such as diabetes and such as hypertension. And the patient may have a remote symptomatic seizure because of a previous stroke, or sometimes this drowsiness or altered consciousness could be post-ictal. Sometimes we will think about psychiatric disorders, but it is very unlikely in the elderly or patients like in these patients. So this will help us to form a picture on which patients we should consider non-convulsive status. In fact, most often we see non-convulsive status in ICU patients who are in a comatose state. So what's the definition of non-convulsive status? It is a prolonged seizure that manifests primarily as altered mental status. So as the name stated, non-convulsive meaning patient doesn't have any convulsions to say this is likely a seizure, but the seizure is prolonged, the non-convulsive seizure is prolonged, and that's why we call it a status. Broadly, we classify non-convulsive status into non-convulsive status with coma, which is number 1, or number 2, non-convulsive status epilepticus without coma, which is subsequently divide them into generalized or focal non-convulsive status. As you can see here, patient with coma usually have poorer prognosis, and patient without coma has a better prognosis. Why are those with coma having a poorer prognosis? This is because of Tremon's study in 1990 showing the progressions in EEG and clinical states of a person with prolonged convulsive seizures. What you can see here on the first picture is that a patient, when they are having seizure status, their seizure may be recurrent, and then subsequently the seizure will merge, become prolonged, and then the seizure will continue and subsequently end with a myoclonus, and at the end with very subtle clinical signs with electromechanical dissociations. And similarly, in the EEG for these patients with a prolonged convulsions, you can see that initially you will see a very fast activity, prolonged, continuous, which subsequently attenuated with periodic discharges, and later on end with a generalized spikes and suppressions of the background and some of the patients may end up with just slowing upper suppressions. Therefore, non-convulsive status can be an end stage of a very prolonged convulsions. So sometimes when someone with a seizure initially and not responsive after the seizure for a long period of time, we should consider this as a non-convulsive status, especially if they are in comatose states. So when to suspect the diagnosis of non-convulsive status? Firstly, clinical signs are unable to reliably make or exclude the diagnosis of non-convulsive status. Most often, we will require EEG to confirm the diagnosis, and therefore, we should consider non-convulsive status in any patient with unexplained and prolonged alterations of consciousness, especially if a past or recent history of epileptic seizures. So these are the indications used in most centers. First one, if the patient have previous seizures, if a patient has a known epilepsy, if the consciousness is fluctuating, or if the patient have impaired consciousness without explainable origin. Sometimes patient may be having a fever and we have treated with antibiotics, but patient didn't recover. This may be also a cause, a patient may have a non-convulsive status epilepticus. However, if you are working at a hospital without a neurologist, or sometimes without EEG, these are the flow chart that I have created to help to assist you in managing or diagnosing non-convulsive status. So let's say this patient is having a non-convulsive or possible non-convulsive status because of unexplained or prolonged altered consciousness, because it's episodic, or because patient have history of epileptic seizures, and you are suspecting non-convulsive status in these patients, which may be either epilepsy related or due to other etiology. If possible, you may do an EEG, but in some hospital, EEG is not available. In Malaysia, when the EEG is performed in the district hospital, we normally take a picture of the EEG and show to a neurologist in the tertiary centers. But sometimes EEG is not always available in all hospitals. In those cases, we will give a trial of a small dose benzodiazepines, which I will illustrate later on what dose to use and to see whether patient has response. Sometimes the response to benzodiazepine help us to make the diagnosis, or if not, we may give them a trial of IV antibiotics, IV anti-seizure medications to see whether patients recover with that. If the patient's conditions or non-convulsive status is due to other cause, we may treat the underlying cause as well to see whether there is a response to those treatments. So management of non-convulsive status is not only to stop the seizure itself, but more importantly, to identify and treat the precipitating or causative factors. Overtreatment can be dangerous, and a lot of these elderly or comatose patients, they are treated with very high dose anesthetic agents leading to burst suppressions, and some of them complicated with infections. In terms of choice of anti-seizure medications, I would like to highlight sodium valproate because I understand IV sodium valproate may not be available in some countries. So some countries are using phenytoin, or some are using sodium valproate or levetiracetam, but IV may not be always available. In those cases, oral high dose sodium valproate crushed into powder or mixed with water given through NG or nasogastric tube can be options in treating or managing non-convulsive status epilepticus. Nonetheless, treatment of non-convulsive can be very challenging. So this is a survey done in Malaysia, which was published this year, and we asked questions related to status epilepticus. And the questions was answered by most tertiary or university hospital and some private or district hospitals as well. In terms of non-convulsive status, this is a question we asked: which one of these medication would you use? And the answers mostly are IV levetiracetam or sodium valproate in a larger hospital, or IV phenytoin and midazolam in the smaller or district hospitals. And because of this, I would like to highlight if levetiracetam and valproate are available in your country, I would like to highlight the dose of these medications. In the past, sodium valproate was first started by giving just 10 milligram per kg, but now we need to remember the dose can be given as high as 40 milligram per kg in sodium valproate, similarly in IV or oral formulations, as I mentioned, giving through NG tubes. Levetiracetam can be given as high as 60 mg per kg with a maximum of 4,500 mg. And this can be given over 10 minutes. Doesn't have to be given infusions for 1 hour as we did in the past. So remember, high dose and fast bolus are the key in treatment of status epilepticus, including non-convulsive status. Treatment on the status can be depending on various non-convulsive status type, which I'll illustrate in my part 3 of the talks on various cases. But nonetheless, I would like to let you know if a patient is in coma, normally the prognosis is poor and the primary aim is to control or treat the etiology rather than the seizure alone. So in conclusion, non-convulsive status has a broad spectrum divided into non-convulsive status with coma or without coma. Sometimes diagnosing without EEG can be challenging. Even with an EEG, I'll show you later, can be challenging as well. However, if we have a high index of suspicions, we can always give them a trial of anti-seizure medications. Point number 3, trial of anti-seizure medications may help in cases with probable non-convulsive status, as I mentioned just now. That's why we should have a low threshold. Just given a small dose of benzodiazepine or giving sodium valproate or phenytoin may help us in making the diagnosis. Prognosis is variable depending on the type of non-convulsive status and underlying etiology. Therefore, as I mentioned, treating the etiology is very, very important. If we can, perform an EEG for confirmations. And last, treatments depends on the types of non-convulsive status. So for this part 1, do you have any questions?
Thank you, Professor Kai Shen Lim. So we just finished for the part 1. And for the participant, you can type your question to the QA box. If you have any question, you can type in the Q&A box.
Okay, so I'll wait for your questions, but meanwhile, I'll just go on with part 2, which is on EEG, and then later on, I'll answer both parts, the question on both sections. EEG criteria, in the past, we are using a similar criteria, but the criteria was not well illustrated as in this flow chart developed by the Salzburg group. And as we can see, the key information is to see whether there is an epileptic form discharges or there are rhythmic non-epileptic form discharges. And I will illustrate the details in more later on. Firstly, what is spatial temporal evolutions? Evolution is defined as at least 2 unequivocal sequential changes. For example, the frequency change from 4 to 4.5 to 6, or the locations spread from 1 to 2 channels to 3 channels subsequently or sequentially. What is so-called improvement with IV anti-seizure or anti-epileptic drugs is that within 10 minutes after anti-epileptic drugs, we should expect a better consciousness, which is clinical improvement or reduction of EEG activity. Rhythmic is mainly for non-epileptic form discharges, which is a repetitions of a waveform, usually slow waves, without any intervals between the consecutive waveforms. Fluctuations is less significant criteria, which is useful for more than 3 or more changes in frequency or morphology or locations. For example, the activity or the frequency change from 4 to 5 Hertz and then go back to 4 Hertz, there is an fluctuations. Whereas sometimes there may be clinical features like minor twitch of the mouth, nystagmus, and the limbs, and so on. But be careful, some of these may be a non-epileptic movement rather than epileptic seizures. So just give you an example. This EEG show that there are periodic discharges, and this activity are about 2.5 hertz. As you can see, shown in the red arrow, and there is an evolutions whereby initially involve the frontal regions and subsequently spread to the temporal or posterior temporal area. So there is a periodic discharges faster or more than 2.5 hertz with evolutions, and we can claim this as non-coercive status. Most often, we should look for these major or important features. Firstly, there is a clear onset. Secondly, there is an evolution in frequency and distributions as well as morphology. There may be clinical correlations. For example, this patient has a jerk here. There may be a response to benzodiazepines whereby the discharges reduce in number or improve more than 90%. Or there are fast activity, we call it modifier or plus modifier, and sometimes has a clear offsets. However, not all of these periodic or rhythmic activities are seizures. Just look at the numbers which I have highlighted in red. You can see that the percentage which is bracketed here are the likelihood of it being a seizure. And you can look at the LPD, which is lateralized periodic discharges with plus. 58% are with seizures. However, if someone is having generalized rhythmic delta activity, which is GRDA, the likelihood of it being a seizure is only 13%. So not all that fulfill the criteria in the Southbridge are seizures, but because of the possibility, we are treating them as status epilepticus. This is a graph which highlights that for anything with lateral periodic discharges, especially with plus modifier, the possibility of it being a seizure is higher. Whereas anything with rhythmic delta activity, LRDA, which is lateralized, or GPD, which is generalized periodic discharges, the frequency does matter. The faster the frequency, the more likely of it being a seizure. Let me give you another example. This is a patient with a periodic discharges, which is bilateral and generalized. But some of them have triphasic morphology. Although their frequency are about 2 hertz in this case, they can be grouped into this generalized or epileptiform discharges with a frequency less than 2.5 per second. However, when you see a triphasic morphology, we should always consider metabolic, toxic, or anoxic causes first before we are considering it being a non-convulsive status. Nonetheless, sometimes a patient with hepatic encephalopathy may have seizure at the same time. And what are the clues to suspect a non-convulsive status in someone with triphasic waves is that when there are transitions from pre-morbid to current ill states within minutes or to hours, very fast. The transition is so fast that you are suspecting this is the onset of the seizure. Or patient did not improve with correction of the metabolic derangements. For example, renal failure patients after dialysis still persistently having these EEG changes, we should consider it being a non-convulsive status. This is a benzodiazepine trial that was published in 2007, and until today, I'm still using these formulations. The midazolam in our center we are using is at 1 milligram per dose. So usually I'll give 1 milligram midazolam and see whether there is a change in EEG or clinical states. Because if we give 10 milligrams straight away, sometimes the EEG will be attenuated, patient will be deeply sedated, and we will not know whether there's an improvement. If 1 milligram doesn't work, we can use 2 milligram and then 3 milligram until 5 milligrams sometimes to see whether there is a response. But don't start with 10 milligram of midazolam straight away. Recently, the Eugene Trinker group also published this additional or other options of anti-seizure trial beside benzodiazepine. These are the criteria which is similar to the Salzburg criteria as I mentioned. And the trial that they use are sodium valproate and levetiracetam. Just to highlight that the dose here is slightly lower than the ESETT trial, which is levetiracetam 40 mg per kg, sodium valproate 30 mg per kg. But they are given in a much shorter durations within 5 minutes and we should expect a response within 10 minutes after these medications. Nonetheless, whenever we see triphasic morphology, we should always suspect could it be a different diagnosis. For example, severe encephalopathy of myoclonus, usually these are post-anoxic encephalopathy. Sometimes can be psychogenic. Recently, I have a patient with prolonged psychogenic pelvic thrusting seizure, which was given benzodiazepine, saturation dropped and was intubated, but EEG was normal. The third one is severe encephalopathy with EEG abnormalities, and in this case, sometimes it's due to various metabolic causes or other infections or sepsis as well. The fourth one is the common or so commonly known as triphasic waves in metabolic encephalopathy, especially liver or renal impairment. The last is Creutzfeldt-Jakob disease that will have generalized periodic discharges, but we know that the patient's myoclonic jerks are not epileptic. They are not going to respond to anti-seizure medications. So in terms of prognosis, the faster the frequency, the better the response, and usually they are associated with better prognosis. This is called FAST criterion, more than 2.5 cycles per second. However, there is a more comprehensive criteria to prognosticate non-coercive status, which is this EMSE. EMSE stands for epidemiology-based mortality score in status epilepticus, which are focusing on 4 components: etiology, and remember in etiology, anoxian infections are always with the poorer prognosis, comorbidity, age, especially the elderly, and EEG, especially burst suppressions. Okay, I finished my part 2. Do you have? Let me see whether there is any questions before I go on, because the last part is the most exciting with cases.
Yeah,
Yes,
I think there are some questions.
Where are they?
So
Okay.
yes, can you see it?
You can see, you click to the Q&As.
Yeah.
Yeah, the Q&A box.
Okay, thank you. Yes, I saw it. So the first question, spatial temporal evolutions are not revolutions. It's difficult to clearly see at tracing. Most often, we will try our best to use various settings. For example, a change in frequency may not be obvious within the first 10 seconds. It may be better seen in the second 10 seconds or over 30 seconds. And because of that, to see the change in frequency, sometimes we will change the time base of the EEG so that we can see 30 seconds in one page. So a change of setting will help us to look at or to look for the evolutions, especially the change in frequency or distributions. Second question is, are there specific criteria for diagnosis, which I've illustrated to you? This is the Salzburg criteria, and I've demonstrated some examples. Third question is, third question is, what symptom can be defined as subtle status epilepticus? So what we are saying is that this subtleness is the clinical subtleness. whereby patient may be having just a very subtle nystagmus of the eyes. If you don't open the eyelids, you may not see that. Sometimes it may be a facial twitch or twitching over the arm or legs. If you don't expose the arm or the legs, you may not see that as well. So these are so-called subtle, but they are continuous. Therefore, we call it status epilepticus. The next question, for focal status, which symptom can be considered focal? Or I will illustrate to you a bit more later on in the cases.
So, excuse me, I also have a question. So,
Yes.
if you suspect it as a status epilepticus and the trial of benzodiazepine doesn't work, should we try for another ASM like valproate, IV valproate, or IV levetiracetam?
Mm. Later on, I'll also show you the cases as well. But most often, in brief, some non-conscious status, or perhaps only about 40 to 50% are responsive to anti-seizure medications, and some are refractory. As we understand, non-conscious status can be at the end stage of a convulsive seizure. And therefore, in most cases, if one anti-seizure medication doesn't work, we may even try the second, the third, the fourth, or even fifth and sixth anti-seizure medications.
We have another two new questions.
But I didn't see that.
You refresh, or you click
Oh,
to
I
new.
should refresh, is it?
Yeah, need to refresh.
Okay, thank you. Dosage of benzodiazepine. Okay, so as I show you the 2007 paper, the one I use is midazolam, 1 milligram each time. So I give 1 milligram, wait for about 3 to 5 minutes. If there's no response, I give another 1 milligram and wait, and then 1 milligram. And usually 4 or 5 milligram will be enough, because after that patient will be very sedative, EEG will slow down, and we will not be able to assess the response. I think that is the question. I can't find any other questions.
I think I can read for you.
Thank you.
I can. Yeah. The abrupt spatiotemporal revolution is difficult to clearly see at tracing.
This is the first question I answer.
Yeah,
This,
you
yeah.
answered already. But there's one question more.
Oh, yes, triphasic pattern.
Yeah, triphasic pattern.
Okay, so let me read. In case of non-conscious suspicions, if the EEG shows a triphasic pattern, we should rule out the possibility of metabolic abnormality first. Yes, this is correct. However, it might require hours to days. Hence, should we deploy midazolam test concomitantly? Okay. First of all, whenever we see a triphasic waves, we always find the answer through the history and blood investigations. If there is hypoxia or CPR, we know this is anoxic encephalopathy. And if the patient have very high urine creatinine or liver impairment, liver enzyme, then we know this is likely metabolic because of the renal and liver impairments, which has been done during admissions most often. If there is no clear answer and patient is not sepsis, there's no fever, and we are suspecting or no other explanation and suspecting non-convulsive status, then that is the case. As I mentioned, I will still try to give IV midazolam if we are unsure or can't find any other explanations. Nonetheless, some of the triphasic waves, which are very typical with AP lag, with state dependency, with very typical triphasic morphology, in those cases, we would not go ahead to try midazolam.
Okay, I think we can move to the part 3.
Okay, then I'll show you some interesting cases. Let me see. There are a total of about 6 cases, but all cases are very short. So I'm showing you non-corrosive status without comma. And first 2 cases are generalized non-corrosive status. So this is a 14 years old boy presented with generalized tonic-clonic seizure. No family history, but he has some episode of absence seizures. There was no identified etiology, and EEG showed frequent bursts of 3 Hz spike and wave, but very frequent. Almost every minute, you will see about 10-second 3 Hz spike and wave. It stop, then come again, and stop and come again. The longest I can see in the EEG is up to 20 to 30 seconds. So what is your diagnosis? Is it a non-corrosive status epilepticus? Answer is yes. Is it generalized? Yes, because EEG is generalized 3 Hz spike and wave. But patient is having history of absence, although during the discharges, patient doesn't have symptom. This, we can call this an absence status epilepticus, or we call it typical absence status epilepticus, because this patient is diagnosed, and this patient can be diagnosed as juvenile absence epilepsy. All right, so this is a case with generalized non-corrosive status, and this is the EEG as I illustrated to you. All the red line are short bursts of discharges, which is over 1 hour. You can see so many pink color line on top, and every individual pink colors will be equivalent to a 3 Hz spike and wave, which is generalized. So for this boy, we have tried phenytoin, it doesn't work. Sodium valproate, levetiracetam. We give midazolam, he becomes sedated and doesn't respond. We give topiramate, high dose oral, 200 milligram, doesn't work, 200 milligram. And we want to try etosuximide, but it will take some time. But when we repeat the EEG, so at the end, we have no other options. We just let him go back, because during these discharges, the patients can still read, can still perform whatever he wants to do. So we let him go home, come back 1 week later, repeat EEG, and these discharges all abort by itself. Recently, my friend told me a similar case, a teenage girl with absence status, and in this patient, my friend managed to get etosuximide. And within 1 day of etosuximide, all the discharges are resolved as well. So this is the first case, absence, typical absence status epilepticus. So this is the second case, a young girl with learning disability, 21 years old, diagnosed with epilepsy at the age of 9. Patient have cognitive intellectual decline. Multiple semiology, right? She got blank staring, unresponsiveness, drop, and other seizure types are drop attacks and generalized tonic-clonic seizure. And sometimes they are tonic. So what is the diagnosis, right? Cognitive impairment, multiple seizure types. The patient is having Lennox-Gastaut syndrome. So EEG show generalized spike and wave. So follow Salzburg criteria, we will call this a non-corrosive status. But even without Salzburg criteria, we will, when we see a prolonged or continuous slow spike and wave complexes, we know that this is Lennox-Gastaut, and some of these discharges are ictal, and some of these discharges are interictal. So what did we do for this patient? We also tried many anti-seizure medications. Tried sodium valproate, lamotrigine topiramate, levetiracetam, and phenobarbital. But we didn't give a high-dose IV phenobarbitons to achieve burst suppressions, because we know that the likelihood is that even if we manage to suppress the brain for 1 or 2 days, all these discharges will recur subsequently. So what we do is we give the family home rescue anti-seizure medications. We give them rectal diazepam if the seizure is prolonged, or we also give them midazolam for the same purpose, just for rescue in prolonged seizures. In some of these patients, we always counsel them for callosotomy or vagus nerve stimulations to reduce the drop or tonic seizures which may cause injury. All right, so I've demonstrated two absence status, but the second case is atypical absence status epilepticus. The subsequent cases are on focal non-convulsive status without coma. So how do we know this is focal? For example, this 48-year-old female having intermittent dysphagia. So if we do an EEG, then we will see a discharges on the left temporal, and she is dysphasic. When the discharges stop, she can speak. Discharges again, she will become dysphasic again. So the dysphasia are correlated with the left temporal EEG discharges. So what is your diagnosis? Is it non-convulsive status? Of course, this is non-convulsive status, but it is focal from the left temporal regions, and we sometimes call this aphasic status. In fact, focal seizure, focal non-convulsive can be presented with multiple phenomena. It can be altered mental states, speech disturbance, subtle myoclonus or nystagmus, as I mentioned just now, unusual behavior. Some patients have psychiatric presentations like anxiety, agitations, or psychosis. Case number 4 is also having focal non-convulsive status epilepticus. So this is a 17-year-old girl, formerly diagnosed with epilepsy at the age of 7. Her seizure is described as sudden pause, blank stare, followed by right head version, rightward rotatory body turning, which means the body turned to the right side, unaware during the event. So we know this is a focal seizure, right? Focal seizure likely coming from the left side. And patient have a cluster of seizure 7 to 8 times prior to admissions because she was busy preparing for her exam. She was sleep deprived for many days to prepare for her exam preparations. So what is the diagnosis? This is her EEG. Beside the rhythmic slow, right? These are all rhythmic delta slowing. There are subtle jerks, as you can see in the EMG recording that I'm showing you here. So when we look carefully, all of these delta slowing may be preceded by a very small sharp waves, and these sharp waves are preceding the jerks of the limbs. So these are subtle status epilepticus, but is focal, and the EEG is rhythmic delta activity less than 2.5 Hertz. So you can see these are all quasi-rhythmic delta activities, more than 0.5 but less than 2.5, as you can see here, and there are some subtle clinical events. The MRI initially was not very certain whether there is a lesion, but when we co-register with the PET scan, we can see a subtle T2 signal change over the left frontal region. So this patient have left frontal focal cortical dysplasia, which was consistent with the indictal discharges. So the patient was intubated because of prolonged motor seizures, tried various IV anesthetic agents, achieved burst suppressions with IV phenobarbs, 1.2 gram, very high dose. But all of this doesn't work. We tried ketamine, doesn't work. We tried midazolam IV infusions, also doesn't work. So at the end of the day, we said, okay, well, there is a lesion. A patient is having focal status. We should consider resective surgery. This is the EEG 3 weeks after operation. You can see that there's no longer discharges. Patient have eye closure and there's alpha rhythm. So EEG normalized after the resections, and she is very well now, seizure free since March this year. This is another focal non-coercive status. Patient having mostly during sleep, having uprolling of eyeballs, occasional tongue biting, but very rare. Her seizure is just 2 seizures a month, only 2 seizures a month. So I said, oh, we are treating her as an outpatient with oral levetiracetam. But when we do the EEG, this is a EEG continuously present for the whole 1 hour recording, which means all these sharp waves over the right frontal central regions is continuous, and the frequency you can count here 1, 2, 3, 4 is 4 hertz here, which is more than 2.5 hertz, and there is a change in frequency over time, which the patient have evolutions. So we diagnose this as non-coercive status, but very subtle because patients have no clinical manifestation at all. We give her midazolam up to 3 milligrams, and she becomes sedated. And therefore, we admit her to the ward. We give her IV sodium valproate 40 milligrams per kg and increase her oral levetiracetam to 1005. And we repeat the EEG the next day. And all these discharges are resolved. So this is another patient with focal non-coercive status who has no clinical symptom at all and responds to IV sodium valproate. However, sometimes, as the question asked us now about triphasic wave, we need to be careful, right? So this elderly patient having diabetes and renal failure, which is likely diabetic nephropathy, on regular dialysis. So she has intermittent obtundation and occasional myoclonus during dialysis because her dialysis is not very smooth. And on examination, she has drowsiness and answered irrelevantly. So is this non-coercive status? So this is her EEG, very typical triphasic morphology periodic waves. And you can see that there is a lag, in this case, from posterior to anterior lag. And they are state dependent. So although patient is having epileptiform discharges, frequency less than 2.5 hertz, we have to always think about metabolic, toxic, or anoxic causes before we consider this as non-coercive status. And I just mentioned before, we are thinking about concomitant non-coercive status only if there is a rapid transitions or patient didn't improve with dialysis in this case. So for triphasic waves, EEG are usually state dependent, more during wakefulness, that can be attenuated with benzodiazepine. This doesn't mean they are epileptic and response to benzodiazepine. They may have myoclonus, they may be misdiagnosed and non-coercive status, but in fact they are metabolic in origins. So in conclusion, I'll show you 5 cases. 2 with generalized absence status. One is typical, one is atypical in Lennox-Gastaut syndrome. I'll show you 1 patient with non-coercive without impaired consciousness and initially treated as outpatients. I've shown you a case whereby patient have aphasia during the discharges or ictal EEG changes, and also a patient with impaired consciousness intubated and end up with a resections or surgical treatment, which results in complete resolutions. However, I've also shown you a case with metabolic encephalopathy, and be careful, the triphasic waves can be sometimes misdiagnosed as non-coercive status. So just an announcement beside the Asna webinar, our AOEC Congress will be held in India in November 2024, which is 1 year from today. Thank you very much.
Thank you very much for your presentation. I think there's some new questions in Q&A box.
Do I need to refresh again?
Yes, I think I can.
Okay.
So,
Can you see?
Yeah, I can. Oh, now I can. Okay. So, where shall I? Okay, now I can see that. So, in case of epileptiform discharges with frequency more than 2.5 Hertz, how much percentage of record durations does this type of activity need to make a diagnosis of non-conscious status? Okay. The EEG suspect criteria is 10 seconds, but most often we will need to make sure that there is a continuous activity for at least 5 to 10 minutes in order to make a diagnosis of status epilepticus. But for the EEG criteria itself, 10 seconds is enough. The next questions, is number of burst suppression or time of burst suppression more important in non-conscious status target treatment? Oh, okay. I assume you're asking whether we should try to achieve burst suppression. Normally, in an elderly with coma, we will not try to achieve burst suppressions because this may increase mortality. Because burst suppressions is associated with higher risk of infections and septicemia. In a young patient who are alert conscious or in any non-conscious status which have no impaired awareness or only mildly impaired or intermittent impaired awareness, as the case I show you, the young boy with absent status or the lady with non-coercive status without impaired awareness, we don't try to give anesthetic agent in these patients because we know that they are still functionally well and there's no urgency to control this seizure activity with anesthetic agent or burst suppressions. The only one that I have mentioned is a young girl with convulsive seizure initially and continuous prolonged EEG changes. The girl which we finally decided to do surgery. That is the only patient we do high dose benzodiazepine or phenobarbital to achieve burst suppressions. So most often burst suppressions are only targeted younger patients with very convulsive nature, and we are hoping to reverse the seizure as fast as possible. The next questions, in case 1, does it mean patient have 2 types of seizure? Yes. Juvenile absence or juvenile myoclonic epilepsy, they can have multiple types of seizure. For example, juvenile absence epilepsy, they can have GTC, generalized tonic-clonic seizure. They can have absence, frequent absence seizures, and some of them may also have occasional myoclonic seizure as well, but very occasional. Similarly, in juvenile myoclonic epilepsy, the patient may have GTC as well as myoclonic seizure at times. I think that's all. Am I right?
I think there's 2 new questions.
2 new questions.
Yes.
Okay.
So do you want me to read it?
Yes, can you?
How long does it take loading dose of oral levetiracetam?
So the waiting time is 10 minutes. And therefore, in the paper, the bolus is given over 5 minutes. And we will wait for 10 minutes to see the response.
Yes. And the last question is what the reason of patient present with nystagmus in non-convulsive status epilepticus?
So these are called subtle status, and subtle status may sometimes involve the eyes, because just imagine it is like a form of very mild clonic jerks. So sometimes the clonic jerks involve the limbs, which is very obvious. Involve the face, we may see it as well. Sometimes there are twitching of the eyelids. And in some patients, there will be a twitch of the eyes, looks like nystagmus, but towards one direction.
Okay. The last question.
Yes.
Wow, thank you so much. So, but I understand non-coercive status is a very challenging topic. I hope today's talks will help you to solve some of your questions. And to introduce Asna, Asna is a neurological association of ASEAN, which is Southeast Asian country, including Vietnam, and of course Indonesia, Thai, Brunei, Singapore, Malaysia, Laos, Cambodia, Myanmar, and Timor-Leste. So we hope to have this webinar every month, and if it's needed, we may have it even more frequent. And we'll let every country host it separately at different months, and covering topics which are not commonly covered by major society. So usually, some of the rare topics we will be will give that the priority.
Okay. So, Dr. Ann, can you close the
Yes.
webinar?
Yeah, thank you. So 1 hour was ended, and thank you for your valuable presentation and interesting cases from Professor Lim Kang Sang. Uh, Hopefully, we will learn a lot about non-convulsive status epilepticus, especially how to diagnose and how to manage in Vietnam situation. And I would like to thank our own audience. I think now is around more than 110 participants till now. And please kindly to review the webinar in the link in the Q&A chat box. Help us to improve the quality of the webinar and the future topics. Thank you a lot for inviting us in the webinar with collab with Asna. And again, thank you, Professor Lim Keng Sen, to be a guest speaker today.
Yeah, thank you for your support and Vietnam Epilepsy Society. Thank you so much.
Yes. And the last thing that I remind you, the next neurology talk, I think in December, right? 20 December. And the next host country is Malaysia. And the
Yes.
title is Fit, Fan, and Funny Turns, presented by Professor Raymond Asman Ali.
Thank you very much. Yeah, you are right.
Thank you.
Thank you.
Yep.
Yeah, again, thank you. See you.
Okay, see you.
Next.
Thank you, everyone. Bye-bye.
Thank you. Bye bye.